Ulcerative colitis and Crohn's disease.
How leaky gut syndrome and the microbiome influence these diseases.
Like that?
I do.
That's
a new...
I'm Dr. Martin Rutherford, and I am a chiropractic physician, been a chiropractic physician since 1979. And currently, the largest part of my practice is functional medicine. I am a certified functional medicine practitioner. This is my colleague,
Dr. Randall Gates. I'm a board-certified chiropractic neurologist as well as being a chiropractor.
And we have blended our disciplines of functional medicine, functional neurology, and frankly, even chiropractic, into a discipline that has ultimately created a chronic pain practice. We treat a variety of different chronic pain syndromes, from fibromyalgia to peripheral neuropathy, restless leg syndrome, chronic fatigue, many neurological issues, dizziness, vertigo, balance, migraine, headaches, reflex sympathetic dystrophy, and on and on and on. And as a result of that, we've had the opportunity to observe a lot of what really are the main factors, the causative factors, but also what are the types of integrated approaches that may be most successful to get these conditions under control and usually be able to maintain them with a minimum influence of drugs and sometimes even a minimum influence of botanicals. So that's what we do. We started sharing this with people a while ago. Ulcerative colitis and Crohn's disease are diseases we've seen. For those of you who watch this every week, yes, I have been diagnosed with one of these. I was diagnosed with ulcerative colitis when I was in chiropractic college, and pretty much told that they were going to have to remove my colon or I was going to get cancer. And so that was an interesting thing to be told. I won't go into what the colonoscopies were like back then, but yeah. So ulcerative colitis is a bowel disease, and Dr. Gates is going to go into this with much more detail. And the reason that we are presenting this is we have found that the center of our universe in beginning to treat pretty much all of these types of chronic pain diseases and chronic neurological diseases seems to start in the digestive bowel system. And you want to call it the gut. We're going to get even a little bit more specific on that today relative to calling it the microbiome. All these are now terms that are coming to be. So ulcerative colitis and Crohn's disease is something that someone might walk in here with because they've heard that we have treated this. So we're going to share with you our observations, how the latest data is very congruent with what we have seen in treating these cases and other cases that were not diagnosed as Crohn's or ulcerative colitis, but were pretty much either similar or heading that way. So let's do an overview of the two of these, why we put them together. As you're going to find out, there are a substantial number of similarities between these two conditions, and let's start with that. So ulcerative colitis, how do you want to go about it? You want to just compare the two, or?
Yeah, so ulcerative colitis in essence is a disease where they talk about it starting from the anus, going proximally. Proximally typically means towards like the center or towards the brain or upwards. And in essence what that means is ulcerative colitis involves the colon. So the last part of your intestines, that's where ulcerative colitis is.
Only the colon.
And pretty much only the colon. It can involve a little bit of the ileum as well.
Okay.
Last part of small intestines. But yes, the rectum, the sigmoid colon, the large intestine, the descending colon. There's all these different names for these areas of your anatomy. If you're watching, you basically see across here, our colon goes down and then it goes into our anus. That's where ulcerative colitis manifests, and it manifests as basically...
So it's about...
It manifests as basically ulcerative lesions throughout that area of your anatomy, and it results in typically bloody diarrhea. Frequently, patients will have 3 to 12 of these diarrhea bowel movements a day. They can become anemic, they can become nutrient deficient, and that is why ulcerative colitis is a very significant issue. Crohn's disease, on the other hand, which is also under the category of inflammatory bowel diseases. That is ulcerative colitis and Crohn's disease. Crohn's disease is more an issue where it can cause lesions anywhere from the mouth to the anus. It can really be anywhere. And they discuss it as having quote-unquote skip lesions. So the lesions may be in one part of the small intestine, and they may be in the esophagus, they may be down perianal, so to speak. And there are different categorizations of Crohn's disease. Sometimes they say, it's a perianal manifestation, or it's more just the small intestines that are involved. And that's how Crohn's disease is really discussed.
Okay, so basically just the colon is about 6 feet, maybe or so, that can be involved, for those of you who may not have the anatomy down, and what Dr. Gates is saying, the 28 or 30 feet of small intestines, esophagus, from your mouth all the way to your anus can be involved in Crohn's disease. That's certainly significant in differentiating them, because that dictates that there's certain surgical procedures, for example, that might work for one that may not work for the other long term, and so on and so forth. And I'm sure you're going to get into that. So the specifics of and also they are both considered autoimmune.
Yes.
Are they both considered autoimmune diseases?
They're both considered autoimmune diseases.
Okay, and I have seen where, and I don't know if this is a big issue or not, but where some people consider the Crohn's disease like an immunodeficiency as opposed to an actual attack, or has that kind of been thrown out the window at this point?
Everything
Dr.
I'm
Gates
reading
is
right
up
now.
to the latest. He was researching this morning before he got on here, so I want to make sure that we're up to the latest. But everything now is kind of autoimmune.
Everything they're talking about right now is basically in an autoimmune context.
Okay, and that's what we've seen. Interestingly enough, in the development of our understanding of these chronic problems, these chronic conditions, whether it's peripheral neuropathy or irritable bowel syndrome, or even migraines, they're just frequently the two major systems that seem to be involved in perpetuating these are stress mechanisms and autoimmune problems. And so that's why I kind of differentiate that a little bit, or don't differentiate it, to understand that. So we do a lot of treatment with the immune system in attempting to suppress it without medications. And I'm sure we're going to get to that, because the next topic that we have here is the present approach, a present medical approach to both of these. And it's slightly different for both of them because they have different immune components.
Right.
Different things are getting attacked.
And with that, I'll go rogue a little bit. I'm going to hit the testing, and then I'll hit some of these medical treatments.
Okay.
And the testing, in essence, if you have these symptoms, if you're having multiple diarrhea, bowel movements a day with or without blood, you're probably going to see a gastroenterologist. The next thing they're going to do is a colonoscopy, because that's their most frequent test. It's a good test, and it allows them to see really what's going on. It's going to allow them to identify if you have ulcerative colitis, or if you have some of these inflammatory bowel lesions that are seen with Crohn's disease. So that's number one. In the literature, they're also discussing the host of other tests that can be done. Some of these are stool tests. So basically, we take a stool sample, and they look at what's termed the fecal calprotectin or the fecal lactoferrin. We throw these out to you as patients because we get questions from all over the globe saying, well, what test should I talk to my doctor about? Because they didn't do a test. And so we just like to give you the test that they discuss in literature so that you can be a little more fluent in your conversations with your doctors. Frequently, the C-reactive protein will be tested, as well as an erythrocyte sedimentation rate. These are markers for inflammation. And then those are really the main tests that I had listed out here. Oh yeah, how did I miss them? The ASCA and the ANCA antibodies also can be run. The ASCA antibody is called an Antisaccharomyces cerevisiae antibody, and the ANCA antibody is basically a neutrophil cytoplasmic antibody. These go up in inflammatory bowel diseases. ASCA is more common with Crohn's disease, because in the Crohn's pathogenesis, the immune system is actually attacking this yeast, the Saccharomyces cerevisiae, creating the inflammation in the bowel. So that's the testing. Forgive me for being specific, but we just kind of wanted to cover that. And they're also discussing magnetic resonance imaging in the context of inflammatory bowel disease. So basically an MRI, they call it an MRE, where they basically look at your your GI tract through there and see if there's inflammation on that form of imaging.
Okay, and again, I do the intakes here, and I do a lot of the intake histories. A lot of those tests don't seem to be being done.
Right, and it's probably the insurance model. A lot of these research articles are coming from an academic setting. And sometimes in an academic setting, insurance will pay them to do these more extensive tests. Whereas if you're going to your gastroenterologist here in Reno, insurance may not want to cover those tests because they just want to pay for the simple colonoscopy. If you get a diagnosis, then great.
And do you think that even if the doctors did those tests, it would change their protocol in treating the patient?
Gosh, that's a tough question. I don't know if I want to answer that.
Well, I'll answer it because I don't think it would. I don't think it would, and that's just based on my interviews with the patients as they came in. I think one of the things we're going to do here is we taught the title was how leaky gut syndrome and the microbiome influence these diseases, and right now we're at the part of kind of explaining to you maybe what ulcerative colitis is and what leaky bowel is in the classic definition of medicine as it stands today in the clinical area. In other words, what is influencing your treatment when patients come in to me, and I do kind of the screenings here. There's patients that are very good candidates for what we do, and there are patients that may not be very good candidates for what we do, and we'll tell you which one of those, which is which later on. But most people are coming in, they're on, most of the ones that come in now, you have a number of things here. Most of them seem to be on Remicade or Humira, or they're waiting to have surgery, or they've already had surgery. And I think that's an important point, because in some of these cases, maybe surgery is corrective, maybe in other cases, maybe it's just a temporary issue. Dr. Gates is going to elaborate on that, but I do think that, you know, I don't know if doing all of that testing, not to throw a wrench in this, is going to change the doctor's recommendations today at this point in time. If they were doing the type of work we were doing, I think it would change their viewpoint on what needed to be done probably significantly.
I would agree. I would say on that point, and I didn't want to answer the original question because we try not to be inflammatory. We're not anti-medicine.
Oh, no, we're not anti-medicine at all.
Sometimes we run into some situations where maybe they're scratching their heads and we're scratching our heads because we're just coming at the problem from different vantage points.
No.
Yeah.
Okay, but we're going to hit a different area later, so I thought maybe that might, some illumination on that might stop some confusion later on. So what is the course of medicine other than, you know, I just talked about Remicade and Humira surgery, but why don't you elaborate on that in a little bit more global issue so that they can understand. Okay. A lot of you have already been through this, but we kind of need to go through this so that we can go to the next spot to indicate what the new data is really finding, and that new data significantly reflects what we've been seeing in our treatment of these cases.
And I think just to wrap up what you're saying, I'll get into this next, is that what patients need to realize is that if you have an atypical case, it may be difficult for the local gastroenterologist to diagnose within the time frame that they have to be with you. And this actually, we have a case going right now where this patient had been to a local gastroenterologist and had been through the standard workup and was referred to a specialty center. She did not go to the specialty center, and it now appears that she probably has Crohn's disease. We came to that conclusion, are working with another medical doctor, and I was discussing with that medical doctor, well, why wasn't that really identified immediately? And their explanation was that, well, you know, that medical doctor who's a gastroenterologist, they have maybe 5 minutes, maybe 8 minutes with the patient. It's an unusual presentation, rather than sticking their head out on
their neck out,
their neck out, so to speak. It's easier just to, quote unquote, kind of punt the case to a specialty center where they have more time, where they can spend an hour with that patient versus the 10 minutes. Yeah. And that's, so again, that's not a knock on the doctor, but that was just an illuminating experience for me. And I think it's good for us to discuss it with patients out there who may be watching, may have an uncertain diagnosis, and they have a lot of symptoms of inflammatory bowel disease and they don't know.
I think a couple of years ago it would have been more controversial. I mean, when you look at what's happening in the insurance industry, and I don't think, I know in doing the intakes, I don't think anybody is surprised at this point that their insurance companies are dictating treatment, or that they're limiting care, or that they're limiting the amount of time that the doctors can spend. And as Dr. Gates said, I mean, we're kind of a specialty center, more or less. And
we can't say specialty.
Oh, we can't say that. Our state law says we can't say specialty. I said we're kind of. I didn't say we were. So we take on unusual cases, and so we spend a lot of time doing our histories and our exams, sometimes up to 2 hours. And that's what Dr. Gates was indicating, and that's why some of these are missed. It's not. Sometimes you'll do a colonoscopy and it'll be early on in the condition, and you won't see the obvious stuff that's there. Patient comes in, my bowels are good, they have every symptom of it. You're kind of going, look, I get it. They don't want to stick their neck out and say, I think you might be heading towards this, and because of legal issues. And so again, we do think that's pertinent, in that you need to understand what you're up against in trying to get these diagnoses done. If you're watching this, you've either been diagnosed with it, or you've been maybe inferred that maybe you're heading that way, and you're looking for more data. Maybe you're looking for different types of treatments, but many of you just need to understand why you're sitting here watching this, thinking you have it, and maybe not being diagnosed for it, or not getting these tests, and so on and so forth. So that I think it's an important thing, just based on the confusion I see on the patients that come in the door. So what is the medical model for treating it right now? For treating either one, for treating ulcerative colitis versus Crohn's. They're two different. There's a lot of similarities, but one's very local and one's very not local. Can be anywhere from your mouth to your rectum.
Clinically, what we see is that lots of times patients are started on the heavy-duty drugs like Remicade, Humira, Cimzia. These are part of the biologic class of medications. You may have heard of them. I say they're heavy-duty because they can be very effective. What these class of medications do is that they're called Tnfalpha antibodies, in essence. So Tnfalpha is an inflammatory signaler in our body. Think of our immune system as being like the military, and think of a inflammatory general, and he's rallying the troops. That's what Tnfalpha kind of is. And so it's coordinating these autoimmune responses. Unfortunately, in a Crohn's or ulcerative colitis patient, that's to the bowel or the intestines, some part of the alimentary canal, mouth to anus, if you have Crohn's. And with that, taking these Tnfalpha antibodies, basically these medications like Humira wipe out Tnfalpha, so then the army, so to speak, calms down to the GI tract, and that's how they work. Unfortunately, these medications are really effective for about a year, and then sometimes they can start to lose their efficacy. There is also something called chimeric antibodies, where our own immune system can start to attack these medications. So these medications are an antibody. They're like an immune cell to one of our immune cells, but then we can start making immune cells to the immune cell that's attacking our immune cell. That kind of makes sense. That's how complicated
I'm sure everybody
gets.
got that out there.
Yeah. But in essence, just know that our immune system can start fighting these medications. That's the basic bottom line.
So we use antibiotics for
sometimes they'll discuss antibiotics, or they'll
steroids for inflammation.
Steroids, they'll talk about steroids, because the nice part about
immune modulating stuff.
And that's the azathioprine. The steroids are good, or they're used commonly because they'll just calm down a flare. So some rheumatologists refer to this as pulling uphill. So some of these medications have a hard time pulling uphill because you're so inflamed. Taking Humira right off the bat may not be enough to calm down your inflammation. So they're going to give you prednisone, then they're going to hit you with Humira. Or the current guidelines, they're discussing using these medications like azathioprine, mercaptopurine. It's just another class of medication that shuts off other inflammatory generals in your immune system. Do that for a while, then go to the biologics like Humira, Cimzia, Remicade. That's kind of the current discussion in the literature, and those research articles are attached to our clipboard today. So
yeah, I think the point that I would make would be, okay, we have that clinical logarithm as to how to treat this, but none of it is a long-term solution.
Right. I mean, it's not a long-term solution in terms of getting to the cause, like what we're discussing.
Right.
Yeah.
And then surgically, as I understand it, you can remove the colon in irritable bowel syndrome.
Or ulcerative colitis.
I mean, I'm sorry, ulcerative colitis. You'd think I would know, because that's what I was told, right? And technically, that's supposed to be in the medical field, it's considered a cure for it. Because it's 6 feet, you can take it out, and it's not affecting all the other different parts of your system, as is Crohn's disease. And Crohn's disease surgery is not considered a cure because it can just keep showing up here and there.
Exactly, it skips around.
And so, but is there more to that?
Basically, 30% of ulcerative colitis patients are going to have one of those major surgeries like you discussed. 80% of Crohn's patients will have one of these surgeries, and they may need more of these surgeries just because, as you said, the lesions skip around. The problem with Crohn's disease is that the lesions get so inflamed that the intestines or the colon, actually there's like a stricture, so not a stricture, but basically fluid and tissue and fecal contents can't get through because there becomes a blockage because the intestines are so inflamed. So that's really why so many Crohn's patients end up getting surgery.
And my understanding of all these surgeries along the GI tract, even bariatric surgeries for weight loss, that once you have violated those intestinal barriers, in other words, the intestines, nothing's supposed to get out. It's supposed to digest, absorb, and then create waste products. Those waste products, to be succinct, are supposed to go into the toilet. They're not supposed to go anywhere into your body. Okay, and it's my understanding that all these surgeries create a defect in that barrier, thus allowing some things to go into the body that don't belong there instead of into the toilet.
I wouldn't disagree with that.
And where I'm going, we're going to talk about later about how leaky gut syndrome soon it causes. So my point being, not unlike when we talk about peripheral neuropathy and B12 deficiencies causing peripheral neuropathy in people who are taking metformin for their blood sugar, and that's a whole nother talk that is online. In other words, the cure is causing the problem.
Right.
So you do the surgery, and ultimately we're going to make an argument here based on the latest research, and it sounds like it's overwhelming, and our observations over a period of 5 years now, that by doing those surgeries, I guess you need to do them because those areas could lead to cancer, but then that also predisposes that person more to intestinal permeability, I would think.
I would agree.
And this is where we're going to go with this.
Yeah.
So you have down a topic here. What does the current scientific literature say about inflammatory bowel disease? Are we to that spot?
We're to that spot. And as we discussed, Dr. Rutherford and I this morning, we were talking about the overwhelming literature on this subject regarding intestinal permeability and these diseases. So 5 years ago, when I joined you, at that point,
I know what he's going to say.
No,
you say leaky gut.
Yeah, at that
everybody
point,
would tell you were
a
quack.
Exactly. Leaky guts was like, oh my gosh, it's like you don't even want to talk about this outside of a closed room because it's so
Just
preposterous.
5 years ago.
Yeah, and I remember reading a lot of the research articles from our mentor, Dr. Vajdani, where he was talking about Th17 responses, interleukin 23. These are, again, inflammatory generals in the immune system. And now everything is shifting. Now everybody's talking about leaky gut syndrome relative to a variety of diseases. And this week, since we focused on these two, it's being readily discussed. In fact, it is the topic of discussion.
Relative to Crohn's disease and colitis.
And I was even listening to a podcast last night from one of the world's foremost gastroenterology infectious disease researchers. He was part of the group that discovered that H. pylori causes stomach ulcers and gastric cancer. And they were basically saying, him and this other gastroenterologist, that the doctor of the future is going to look at the microbiome first. Which is the bacteria in our gut and how that influences, those bacteria, how they influence our overall health, our weight, our immune system, how we think. It's really, really interesting. I almost fell off my chair while I was eating dinner when I heard him say that, because it was just kind of a nice verification, because this is a direction that Dr. Rutherford and I have been in for the last 5 years. We've really been trying to push the envelope, not egotistically, I'm saying this, but again, it's just a nice verification. So what does the current scientific literature say about inflammatory bowel disease and leaky gut syndrome? In essence, what they're saying is that the intestinal permeability or the intestinal barrier, as Dr. Rutherford said, this tube that we want to think of, it has broken down. You have holes in the tube. The tube should allow carbohydrates in the form of certain sugar molecules, amino acids from that steak you ate, fatty acids, to filter out of the tube into your bloodstream so that you can get nutrition. Right. Unfortunately, the big molecules...
Everything else should go in the toilet.
Or stay in the tube. Unfortunately, the big molecules now, we're finding, can get through the tube, and this is called leaky gut syndrome. Some of these big molecules are from what we're eating. They may be gluten proteins. Some of these big molecules may be pieces of bacteria. So now all of a sudden, the immune system starts basically freaking out because it starts seeing these huge molecules that basically look like bacteria or are bacteria, and it starts attacking them.
Yeah, your bloodstream is supposed to be pristine. It's supposed to be sterile. As soon as it sees this, it's like seeing even like a food particle. Bacteria makes sense to a lot of people, but even a food particle that would get through would be viewed as an invader, a foreign object, and particularly a bad bacteria is going to be attacked, and you're going to create the immune response you're about to go into.
Right.
So this is huge. This is like so important for you to understand if you have either one of these two, that it cannot be overstated.
It can't. And I attached an article last night from the Journal of Immunology Research 2015, where they're discussing the wide scope of this leaky gut syndrome in terms of our overall health and disease, from multiple sclerosis to autism to migraine headaches to depression to anxiety. These are mainly neurological conditions I'm talking about. To rheumatoid arthritis, to diabetes type 1, and now we're talking about ulcerative colitis and Crohn's disease. Really, the issue is that leaky gut syndrome seems to be really, really common now. And the prevalence of all these diseases, all
it's
these
like if you're
autoimmune
human
diseases,
and you have anything, you probably have it.
Yeah, at some level.
That defines really common.
What we're finding is that the leaky gut syndrome is basically crossing all barriers.
Yeah, and we talked about this before we understood more specifically what was going on, thanks to Dr. Gates' relentless attack on the world of research. It felt like all of these bowel syndromes were some sort of a flow from just inflammation to ultimately to irritable bowel syndrome to ulcerative colitis to Crohn's, and that may be rather simplistic, but it was kind of the seed of saying, and then you treat it, and then the treatment in and of itself is I don't know how much we're going to talk about that. It can be a little complex. It may be a little different for each person, but as you treat it, then we started seeing all the things that are being reflected in the research that you're sharing with them now. People's arthritis going away, their neurological problems improving, and dramatically, and so yeah, this is kind of where it's at. It is the gut, that bacteria is.
It's a major issue, and you're probably wondering,
major issue.
Well, if this is so common, then why do some people get multiple sclerosis, and why do some people get ulcerative colitis? And yes, there are other mechanisms associated with these diseases, but we're trying to tie this together for you.
Right.
And it's your genetics. So genetics is a piece of the puzzle, such that if you have leaky gut syndrome combined with factors such as stress, combined with other environmental factors, and you have the genetics for this X condition, then you're probably going to get that condition. So everyone with leaky gut syndrome isn't going to get ulcerative colitis or Crohn's disease, just like we talked about a couple weeks ago with ankylosing spondylitis, where we discussed the Klebsiella bacteria in the gut. When the immune system attacks it, that creates specific immune chemicals that attack the spine and cause the spine to fuse. Well, you have to have the genetics for that to happen.
I just read an article recently that said that the genetics, the understanding of how genetics are involved with Crohn's disease are more specific than for any other disease that's out there.
Okay.
That they can look at the factors there and say, you're going to get it.
And exactly, that is very much the case. Frequently, if one individual has Crohn's in the family, several other individuals will have it. And if you have a family member with Crohn's, and our recommendation would be you need to see somebody and have your leaky gut evaluated, or have this condition called leaky gut evaluated, because that may be the crux, in terms of your future development.
Yeah.
But going on, so what we find with ulcerative colitis and Crohn's disease is that the barrier of this tube breaks down for whatever reason. There's some discussion on inflammation in the GI tract due to bacterial imbalances. There's also discussion of how genetics interplay with other normal bacteria in the intestines and can allow the leaky gut syndrome specifically to manifest. That's in some of the articles that we attached today. And then pieces of bacteria, or whole bacteria, start kind of getting through this tube. The immune system starts attacking them, and it creates this autoimmune response to the GI tract, and that can result in Crohn's disease or ulcerative colitis. Some specific bacteria are associated with Crohn's and yeast, those being Klebsiella pneumonia, a bacteria we talked about a few weeks ago that's associated with Crohn's, as well as the yeast Saccharomyces cerevisiae. And then with ulcerative colitis, I haven't seen a certain bacteria identified with it. It's just more this leaky gut syndrome. The immune system starts attacking the bacterial components, and then it starts killing the intestines. Now, interestingly, there is a lot of discussion on parasites. So a few years ago, the hypothesis with Crohn's disease was that we're too clean. We don't grow up with enough infections. So these researchers basically infected Crohn's disease patients with a parasite called Trichuris. And I believe it's a nematode, doesn't matter. So it's a certain type of parasitic worm. They put them in the intestinal tract of Crohn's disease patients. The early research was favorable, thinking that it was going to help them because the immune system would be attacking the parasite rather than the GI tract. But unfortunately, the long-term studies were not as favorable, so now this is not a treatment modality.
That surprises me, because basically what we see is that they would think that, frankly, not to bag the researchers. I get where they're going, but pretty much part of our whole approach is remove everything that flares up the immune system.
And that brings up a great point.
Autoimmune, so the immune condition doesn't attack the tissues that are already susceptible to being attacked, wherever they are, in your intestines, or in your thyroid, or in your brain, or whatever.
So what I forecast with this microbiome research frontier is that the breaks are going to be a model such as that. The model in research is we want to do one thing for one condition and see what happens. And unfortunately, this is such a complicated environment in our intestines that just removing one variable frequently in our clinical experience is not enough. It's like us just saying, okay, like you're saying, we have to eliminate the parasite. Yes, we do that. But we do that in the context of putting people on a certain diet. We change that diet frequently with our patients to find out the right diet for basically their microbiome. That's what we're looking for.
And that diet has to be specific to that person, not to this diet or to that diet. And the microbiome and their food sensitivities.
Right, yeah. I mean, with Crohn's disease, they talk about food sensitivities galore.
Pristinely figured out.
So most gastroenterologists acknowledge that their Crohn's disease patients say that they react to foods, but they react to so many foods, everybody just puts their hands up and say, we don't know how to figure it out.
Because the testing that that is done for food sensitivities today is seriously flawed, according to Dr. Donnie's rather humorous lecture, I thought, on it. We saw a lecture on it. We had already seen that. And again, we're not trying to bag you. We're just saying, so the doctor now reads an article and understands that these food sensitivities may be a significant part of trying to help this patient. And maybe he doesn't care what the insurance company says, so he orders these tests, and then this patient comes back with 56 different food allergies. And that's not the way to do it.
Right.
So
there's that piece, and there's the piece of what does the microbiome like to eat and what do they not like to eat. That has led to the evolution of what's termed the SCD diet, the specific carbohydrate diet for Crohn's disease patients, where they found that certain carbohydrates are okay for Crohn's patients and others are not. And you have to go on this elimination diet, and then you introduce them, and then you puree your vegetables. And there is credibility to a lot of it. But then other people are saying, no, you need the low FODMAP diet, which goes with IBS, but we're seeing Crohn's patients and ulcerative colitis patients react to certain FODMAPs. Then other people are saying, well, SIBO is a component of all this. That's small intestinal bacterial overgrowth, so we need to go to the SIBO-specific diet. Hopefully you're seeing how complex this can get pretty quickly.
Yeah.
And so we use variations of all these different diets in certain settings, and sometimes we've actually created our second Power Health diet here just recently.
Just yesterday.
And we're going to see how that goes. But really, that second Power Health diet is based on our clinical experience with the toughest of the tough gut patients and figuring out a way of really, really determining what their food intolerances are.
And if you actually have Crohn's disease,
perspective, but a bacterial perspective.
Okay.
Yeah. If you have Crohn's disease,
then you were in the toughest of the toughest category. Yeah, and that was a good presentation on, you know, and just the way Dr. Gates presented it on the complexities, but I don't know if I want to say the insanity, but out there, everybody this is a complex subject, and there's a wide variety of physicians out there, non-physicians and secondary physicians who are looking for the silver bullet. Boy, I'll tell you what, if you got Crohn's and you want to control this thing without drugs or surgery, there is no silver bullet. This is a complex issue that can be figured out. You didn't even mention stress. I mean, stress basically, if you're in like a post-traumatic stress syndrome, or you're just chronically stressed and you're flooding your intestines with stress hormones, and you're doing all the right things, and you just happen to get the right diet, and your stress hormones are attacking the inside of your gut and perpetuating your problem. All of these factors have to be considered in not only healing that leaky gut, but also managing that microbiome. It's a complex issue. It can be done. It can be done. And I don't know where you're going from that, because that was the end of the notes that you gave me this morning.
So from that, I want to talk about how we test for leaky gut syndrome to a certain degree. Testing the microbiome is really difficult, because most of these organisms in the microbiome are anaerobic, so they don't grow on oxygen. So it's not like we can just take a stool sample and culture it out and say, oh, you have too many of these bad bacteria, or you have these good bacteria, we need to work with those. That's the difficulty of the microbiome. And so we test for intestinal barrier integrity. We use the Cyrex Array 2 for that test. The Cyrex Array 2 is fantastic because, just so you know, if you had a cheeseburger, you're going to absorb some bacterial components. But the Cyrex Array 2 is good because it basically is not going to detect those transient elevations in bacterial components. It's going to detect sustained long-term elevations in bacterial components, or sustained long-term breakdown of the proteins binding your intestinal cells together. And so it allows us to really quantify what's going on, and then also determine how severe it is. And Dr. Rutherford and I use that to gauge our treatment in terms of how much repair we're going to do to your GI tract. And that GI repair is really a multimodal approach, which consists of certain dietary therapies, getting rid of food intolerances, figuring out the right diet for the microbiome, then using other agents that may be designed to kill off bad bacteria,
stress modification,
while also doing other strategies to heal the intestinal epithelial tissue. That's how we approach it.
Yeah.
And through that approach, we seem to be seeing these fantastic results with a myriad of conditions, both neurological, immunological, endocrine disorders, and it's pretty fun.
Yeah. And so it's been a long time putting that together, and there are a lot of people out there who are doing a lot of variations of this. It can be very frustrating for the patient. And just understand, this is a complex issue. If you've been to different places and you've tried the alternatives, a lot more people are going to alternatives now. I have folks that come in and are taking probiotics, or they're taking fish oil, or they're increasing their fiber, or they tried one of the diets that Dr. Gates has talked about. Maybe they've taken some herbs and botanicals, maybe they've made them worse. All of these things are out there in the alternative field. Obviously, we've just said we're not anti-medicine, but clearly we're not anti-alternative either. More people would consider us alternative than not, but we do work in an integrated fashion with the medical community when the case clearly calls for it. And therein lies the complexity of it. I don't see the medical model embracing this complex of an approach to it anytime in the near future. I'm seeing a lot of, we have a local hospital here who has a huge marketing campaign going on. Your Best Medicine, I think it's called, and they have advertisements on the radio and on the television. It says your best medicine is going and doing snow bunnies or whatever you're calling it.
Right. The farmer's market.
Today it's the farm. Now it's the farmer's market, and go see these tomatoes and so on and so forth. So it's nice that that aspect is being emphasized, because dietary stress management is huge. You're going to need to do more than go out and lay in the snow and make whatever they call those things, snow angels or something like that. But it is good that they are emphasizing the food aspect, because it wasn't long ago where people had a difficult time understanding how much food could change their microbiome or help them. But it really is complex. I would say food is probably 30, 40, 50% of you getting better, figuring out your food sensitivities and getting your diet under control. But it's probably, once you then are able to diagnose the gut, which as Dr. Gates said, is very difficult. What he was saying is there's a lot of tests out there that will tell you about the parasites, the Saccharomyces, but how accurate are they? We haven't found them to be very accurate. And so what Dr. Gates was also saying was he's predicting the future is going to be that you're going to be dealing with global issues to fix this, not specific issues. So you're going to be dealing more with the immune system. And what do you do to calm down the immune system? And the stress system, what are you going to do to calm down the stress system? We're not talking about drugs. We're not talking about specifically going in there and giving you a medication for this one thing. It's difficult to find out if you have a parasite in there, even today, to see if that's affecting your immune system or attacking it. So there's just a lot of challenges now. What Dr. Gates was saying, that this one test, once it quantifies the leaky gut, and once it quantifies the overlying factor that is the sustained finding in that test that he talked about, you can take a pretty good shot at it, but you need to understand the rest of what you need to do to take a good shot at it, to get that inflammatory bowel, to get that immune system to calm down, to get healing in the gut. We've had good success with Crohn's disease. I suspect we've had more Crohn's disease come in here than has been diagnosed. We just had one of those the other day. Right. Did you just mention that? Did you mention that on film? Or was that us talking before?
We were talking before, and we were talking about one Crohn's patient who came to us who was doing well as long as they could stay on the diet. But then they veered from the diet for a number of months, and then their symptoms just got completely exacerbated. It was really beyond repair as to what could be naturally done at that point. They required prednisone, they required hospitalization. So that's why there is some level of urgency in getting to these issues early on, in our opinion, and the current scientific literature supports that. And just as you and I were discussing yesterday, it is forecasted for these medications like Humira, it's a whole class of medications, that they're going to cost us $1 trillion over the next decade, just here in America, $1 trillion. And now they're talking about the use of these drugs called the biosimilars, which are basically like Humira, but they're not as expensive. And they're going to save us like $50 billion over the next 10 years. So rather than spending $1 trillion, we're going to spend $950 billion, which we kind of chuckle to ourselves, because that's our current model. And that's where our healthcare system is going. And that's why people who are in this field of age management medicine, integrative medicine, alternative medicine, functional neurology are saying the path we're on is not sustainable. We have said it 100 times that by 2050, 2/3 of us are going to be obese and 1/3 of us will be diabetic. 1/6 of us right now have autoimmune issues. And all these research articles are talking about how autoimmune problems are becoming more prevalent. Yeah. We don't know why. Well, that's where we have to start. We just have to say our current approach maybe is not the best approach. These medications are not bad, but what can we do as a precursor to you needing to be on Humira to maybe slow down the course of this illness based on the current scientific literature?
And what we need to do is look at, if you have these conditions, you need to look at the leaky gut. You need to look at the microbiome, because these are the things that are collapsing our healthcare system and will continue to do so. But more importantly, if you're watching this and you have it, you know, it's pretty scary having this stuff. You don't know what's going on. You're doing the treatment. It's going here. It's going there. You're wondering, like, am I ever going to get better? Am I going to have a surgery? Am I going to have a second, a third, or fourth surgery in the case of Crohn's disease? So we encourage you to investigate the attachments to this. This is a very serious issue, not just because of Crohn's, but because, as we stated in the beginning, as many of you know, if you have either one of these, you probably have a lot of other health issues that and you may not be aware that they're connected completely to what's going on in your gut. And that gut gets substantially better. Your gut gets 75, 80, 90% better. You will feel like a whole different human being, not just in your gut, but in a lot of different ways. So please, you know, if you have this, follow up on this. It's an important topic. And I almost said, if you have any questions. We've stopped taking questions because it's been overwhelming as to how many questions we've been getting, and we still get them. But please review the attached references, and I hope that this is helpful to you.
Okay. Thank you for watching.
Yeah.